Hi, good night, everyone. My name is Danielle Lutchman, one of the neurosurgery house officers in San Fernando General. Tonight, I'll be presenting embryonal tumors of the central nervous system. Embryonal tumors are a diverse category of malignancies featuring immature tumor cells that resemble neural progenitors. It is divided into medulloblastomas and other rare non-medulloblastomas, CNS tumors, many of which exhibit the C19MC region of chromosome 19 or amplification of this gene. Many of these tumors were formerly encompassed by the term primitive neuroectodermal tumors, which has been since eliminated from the diagnostic lexicon. Embryonal tumor comprise of medulloblastoma, which can further be molecularly defined and histologically defined, as well as other CNS embryonal tumors. These include atypical teratoid rhabdoid tumors, embryonal tumor with multilayered rosettes, CNS neuroblastoma, FOXR2 activated, CNS tumor with B-core internal tandem, duplication, and CNS tumor not otherwise specified. Starting with the clinical presentation, almost all patients have early signs of elevated intracranial pressure that is associated with headaches early in the morning that are relieved over the course of the day. Patients with Cushing's triad, that is hypertension with a widening pulse pressure, bradycardia, and irregular respiration, usually have impending herniation and need immediate treatment. The tumor in the cerebellum can lead to ataxia and truncal unsteadiness. If the brainstem is involved, it may lead to cranial nerve palsies that may present as diplopia, hearing loss, facial weakness, and a head tilt. Fundoscopy may show optic pallor and papilledema. Paralysis of the abducens nerve may lead to the inability to abduct the eye. The sun setting sign may be seen in some infants, and measurements of the head circumference in infants may reveal macrocephaly. Medulloblastomas. These are the most common malignant brain tumors in children, constituting nearly 20% of all pediatric brain tumors. They account for 68% of all embryonal tumors. It is categorized as an embryonal neuroepithelial tumor, WHO grade 4, that typically occurs in the posterior fossa, that is the cerebellum or the dorsal brainstem of children. In the cerebellum, they typically arise in the vermis near the apex of the roof of the fourth ventricle or the fastigium. Surgical resection, followed by radiation and chemotherapy, are the mainstay of treatment, with 5-year survival rates ranging between 20 and 100%. This wide range is multifactorial, owing in part to age at diagnosis, presence of metastases at diagnosis, subgroup variants of medulloblastoma, and concurrent cytogenetic abnormalities, including copy number variations. They often present with signs and symptoms of obstructive hydrocephalus, including headaches and nausea and vomiting, and ataxia. Symptoms specific to infants include increased head circumference, sun-setting sign, failure to thrive, and lethargy. So, as stated before, the classification of medulloblastomas can be histologically defined or molecularly defined. So we'll start with the histological classification. And there are 4 variants. So the classic variant of medulloblastomas are by far the most frequently encountered in clinical practice, accounting for up to 72% of all medulloblastomas. These are characterized by relatively round nuclei, the absence of increased cell size, and the absence of frequent mitotic activity. Homocyte rosettes are frequently encountered in this variant. Intrinsic desmoplasia is rare in this variant, and when desmoplasia is present, it is typically associated with involvement of the leptomeninges by the tumor. Similarly, nodules of differentiation are rare, but when present are not outlined by pericellular collagen as detected by reticulin staining. Next, we have desmoplastic nodula in point B. This is a variant of medulloblastoma that is characterized by nodules of neurocytic differentiation with intervening embryonal elements. The desmoplasia associated with this tumor refers to the propensity of these tumors to have pericellular collagen deposits, which is detectable by reticulin deposition. Medulloblastomas with extensive nodularity. This is a special variant of desmoplastic nodular medulloblastomas. This histological variant typically presents in infants and is frequently more midline than the more conventional desmoplastic nodular tumors. As the name implies, these tumors are dominated by nodules rather than primitive elements. The nodules tend to be irregular and coalesce together in many examples. It is typical to identify a streaming pattern in these tumors in which linear arrays of neurocytic cells connect adjacent nodules. Next, we have the large cell and anaplastic variant. The large cell variant represents a histologic variant in itself, which shows increased cell size, round cell morphology, and prominent nucleoli. Anaplastic. So, overt pleomorphism can be seen in the anaplastic variant and often associates with anaplastic features, such as frequent mitotic activity and apoptosis. Here we have some slides. So, histologically, medulloblastoma groups, the four histologic classification can be seen in these slides. Classic variant, seen in A, B, C, and D, are characterized by small cells with round to ovoid nuclei, a high nuclear cytoplasm ratio, which can be seen in slide A. Frequent homoroid rosettes, which can be seen in B, no significant cytologic pleomorphism or cell molding, which can be seen in C, and a slight increase in cell size and cytologic pleomorphism, which can be seen in D. The desmoplastic nodular variant can be seen in E, F, G, and H. It's characterized by nodules of neurocytic differentiation surrounded by more primitive internodular areas, which can be seen in E and G. The differentiated nodules show desmoplasia surrounding the nodules, which can be detected by the pericellular reticulin deposition, which can be seen in H. Medulloblastoma with extensive nodularity can be seen in I, J, K, and L. It is characterized by a high proportion of differentiated elements compared to primitive internodular elements. The nodules in this variant often coalesce together, forming irregular patterns accompanied by a pattern of linear streaming between nodules. Similar to other desmoplastic nodular tumor, these show reticulin deposition in the internodular regions, which can be seen in L. The large cell anaplastic variants can be seen in M, N, O, and P. Starting with anaplastic variant, which can be seen in M and N, it shows increased cell size, cytologic pleomorphism, cell molding and wrapping, frequent mitotic activity, and apoptotic bodies. The large cell variant is characterized by large, discohesive cells with prominent nucleoli, and this can be seen in O and P. Now we move on to the molecular classification. WNT activated. This is the least common type of medulloblastoma and has by far the best prognosis, with the vast majority achieving a cure with appropriate therapy. They're usually seen in children and to a lesser degree adults. They typically arise from the region surrounding the foramen of Luschka and middle cerebellar peduncle. The majority of these tumors are encountered in children, with a peak incidence being between 7 and 14 years, and a substantial minority occurring in adults. They are, however, almost never diagnosed in infants. Next, we have the medulloblastoma sonic hedgehog activated tumor, or SHH. These are malignant tumors of the central nervous system, and they can either be TP53 mutant or wild type. They are usually present in children less than 3 years. So the wild type, they are twice as common than those with the TP53 mutation and account for approximately 20% of all medulloblastomas. Male to female ratio is 1:1, and They are most frequently found in adults older than 16 years and infants less than 4 years. The mutants account for only 10%, which is half of the percentage of the wild type. So 10% of all medulloblastomas, and they occur primarily in children and tend to favor males to female, with the male to female ratio being 3 to 1. Here we have a little summary table comparing the different medulloblastoma subgroups. So the WNT activated subgroup or subtype has the most favorable prognosis. The molecular or genetic mutation would be TP53, CTNNB1, SMARCA4, and DDX3X. They tend to have classic large cell anaplastic histology and usually occur in children and teens. The TP53 mutant and the TP53 wild type both occur in infants and adults. They also both have large cell anaplastic and desmoplastic nodular histology, but the wild type also has extensive nodularity, or medulloblastoma with extensive nodularity. Prognosis is very poor in the mutant and is intermediate to poor in the wild type. Next, we have the non-WNT, non-SHH groups, 3 and 4. Group 3 has the worst prognosis, and it occurs in infants and children. Group 4 also occurs in infants and children, but can occur in adults as well. They both tend to have the classic as well as the large cell and anaplastic histologies. Now, moving on to imaging of medulloblastoma. Here we have a macroscopic example of a medulloblastoma in a 6-year-old. It shows a soft, fleshy tumor with areas of necrosis in the center. Although the tumor appears well circumscribed, there's usually some infiltration at the edges into the surrounding brain parenchyma. CT imaging So, on CT, medulloblastomas often appear as a mass arising from the vermis, resulting in effacement of the fourth ventricle and the basal cisterns and obstructive hydrocephalus. They can also occur more laterally in the cerebellum. They usually are hyperdense, and cyst formation and necrosis is common, especially in older patients. Calcification can also be seen in 10 to 20% of the patients. Enhancement is present in over 90% of cases and is usually prominent. On MRI, T1 tends to show the tumor's hypo-intense to gray matter. T1 with contrast, overall 90% of them enhance, often heterogeneously. WNT activated tumors tend to vividly enhance, while group 4 tumors tend to enhance less. T2 flare, they are iso to hyperintense to gray matter, heterogeneous due to calcification, necrosis, and cyst formation. Surrounding edema can be common. There is high DWI signal and low ADC values. Here we have an example of medulloblastoma in a 6-year-old female. This is a T1 axial, a T2 axial, then here's a T2 axial showing hydrocephalus, and T1 sagittal with contrast showing some tonsillar herniation. These images show a very large mass located centrally within the posterior fossa. It has a high T2 signal and low T1 signal with only patchy contrast enhancement. No normal vermis can be identified, as the mass is likely to have arisen from it, completely effacing the fourth ventricle and abutting the dorsal aspect of the brainstem without convincing evidence of extension into the pons. As a result of the mass, result of the mass effect on the fourth ventricle, significant obstructive hydrocephalus has developed, which can be seen in image C, with transependymal edema noted particularly around the frontal and the occipital horns. On the sagittal image, we can see tonsillar herniation. Staging. So staging is done post-operatively for medulloblastomas, and M0 shows no metastases, M1 shows microscopic tumor cells in the CSF, M2 shows gross nodular seeding in the cerebellar and the cerebral subarachnoid space or in the third or lateral ventricles. M3 shows gross nodular seeding in the spinal subarachnoid space, and M4 shows metastases outside of the CNS. Treatment and prognosis. Treatment typically consists of surgical resection, radiation therapy, and chemotherapy. In general, the tumors are quite radiosensitive, and sometimes a VP shunt is required in 35% of children who undergo resection. Cerebellar mutism syndrome may occur after surgical resection of medulloblastomas. Prognosis is most strongly influenced by molecular subtypes. So the WNT has a very good, well, WNT activated has a very good prognosis. SHH activated, wild type and mutant, they tend to have a good prognosis in infants and intermediate prognosis otherwise. Group 3 has a very poor prognosis, and Group 4 has an intermediate prognosis. Traditionally, and still relevant in addition to molecular characteristics, prognosis is considered poor if the patient is diagnosed at a young age. If there's incomplete surgical resection, so if there's more than 1.5 cm cube of residual tumor, and the presence of CSF metastases at the time of diagnosis. Prognosis continued. Histological features also have an effect on prognosis, so desmoplastic and nodular histology have a better outlook than large cell anaplastic. So no CSF metastases, complete surgical resection, and a negative CERB2 expression, or which is also called the HER2 new oncogene. This can show a 5-year survival rate of up to 100%. If they have no CSF metastases, complete surgical resection, and a positive CERB2 expression, 5-year survival rate can drop to around 54%. If there are CSF metastases and or incomplete surgical resection, 5-year survival rate can be 20%. Now, I'd like to move on to other embryonal tumors of the CNS. So going back to the slide listing the embryonal tumors of the CNS, we would like to start with atypical teratoid rhabdoid tumors. Atypical teratoid rhabdoid tumors are uncommon WHO grade 4 tumors, which in the vast majority of cases occur in young children less than 2 years of age. It most frequently presents as a posterior fossa mass and often resemble medulloblastomas by imaging and H&E staining, and the diagnosis requires cytogenetic analysis of the tissue. Rhabdoid cells are the hallmark of this tumor, but only comprise a fraction of the tumor and are not required for the diagnosis provided genetic of DNA methylation changes are compatible. Other portions of the tumor are indistinguishable on imaging and histology from a medulloblastoma or embryonal tumor with multilayered rosettes. This figure shows the classic rhabdoid morphology with an eosinophilic globular cytoplasmic inclusion. The vast majority of these tumors have inactivation of both copies of the SMARCB1 gene, also known as INI1 BAF47 or HSNF5. In a small minority of cases, it is the SMARC4A4 that is inactivated. Additionally, these tumors can be divided into 3 subgroups according to DNA methylation profiling, so the SHH, the TYR, and the MYC. To make the diagnosis, either the SMARCB1 or SMARCA4 mutations or compatible DNA methylation profiling need to be identified. Rhabdoid cells usually tend to demonstrate EMA positive, vimentin positive, and SMA positive. Treatment and prognosis. Surgery with debulking can be offered in some cases. Tumors can demonstrate leptomeningeal dissemination. These tumors tend to have a much poorer prognosis than medulloblastoma, with little, if any, response to chemotherapy, and that usually occurring within a year of diagnosis. Differential diagnosis can include embryonal tumor with multilayered rosettes, medulloblastomas, among others. Next, I'd like to talk about embryonal tumors with multilayered rosettes. These are WHO grade 4 embryonal tumor demonstrating multilayered rosettes and one of three histological patterns that we will elaborate next. They typically exhibit amplification in the C19MC region of chromosome 19, or rarely a DICER1 mutation, and they may develop in the cerebrum, the brainstem, or the cerebellum. They usually affect children less than 4 years old, with the vast majority being less than 2 years old. Right, so these tumors demonstrate one of three histological patterns: embryonal tumor with abundant neuropil and true rosettes, ependymoblastomas, and medulloepitheliomas. Post-operative staging is similar to that of medulloblastoma, with M0 being no evidence of subarachnoid or hematogenous metastases, and 4 being metastases outside of the central nervous system. Treatment and prognosis. Treatment of these tumors includes surgical resection, systemic chemotherapy, and craniospinal radiation. Unfortunately, prognosis is dismal, with articles reporting 75% of cases having died within a median survival of 9 months. Differential diagnosis can include medulloblastoma, atypical teratoid rhabdoid tumors, CNS tumors with pico-internal tandem duplication. Next, we have CNS neuroblastoma FOXR2 activated. These tumors are rare and occur in young children. It is a supratentorial tumor with seldom an interventricular localization. It usually demonstrates poorly differentiated cells with embryonic appearance, high nucleus to cytoplasm ratio, round-shaped nuclei, and sometimes brisk mitotic proliferation. It may show necrosis, high vascularity, endothelial proliferation, nuclear pleomorphism, and perivascular pseudorosettes. Synaptophysin and OLIG2 are often positive, whereas vimentin and GFAP are absent in most cases. Molecular markers. Alteration of the FOXR2 locus on chromosome XP11.21 and a specific methylation profile are characteristic of this tumor. These tumors appear as a mixed cystic and solid supratentorial mass with sharp margins and necrosis. In some cases, leptomeningeal dissemination has been described. Differential diagnosis include atypical teratoid rhabdoid tumors, cribriform neuroepithelial tumors, among others. And in conclusion, I'd just like to use this table to summarize the non-medulloblastoma embryonal tumors of the CNS. So, embryonal tumors with multilayered rosettes typically occur 0 to 4 years old, but tend to occur more often in patients less than 2 years old. Histology may show small cells forming multilayered rosettes, fibrillary zones. Prognosis is poor. Atypical teratoid rhabdoid tumors tend to occur in patients less than 3 years old. Prognosis is also very poor. Histology tends to show spindle-shaped cells clustered in a papillary or trabecular pattern. SMARCB1 locus at the 22q11.2 gene is the genetic mutation. CNS neuroblastoma, so the genetic mutation is FOXR2 NKX211P gain. Prognosis is poor again. They can occur from 4 weeks to 20 years, and histology can show zones of neurocytic differentiation and densely packed primitive embryonal cells. High-grade neuroepithelial tumor with BECO internal tandem duplication tend to occur from 7 months to 22 years. Cells can be spindle to oval with chromatin, microcytic features, perivascular pseudorosettes, and fibrillary cytoplasmic processes. Prognosis again is poor. And the gene mutation will be somatic internal tandem duplications in the third end of the BECO gene. So this concludes my presentation on embryonal tumors of the central nervous system, and these are my references.